Okay, good evening, everybody. Thank you very much for joining us on MSART's webinar series for 2024. The Malaysian Society of Assisted Reproductive Technology is very happy to be able to host a series of webinars throughout the year. I'm glad that everyone has taken the time out of their busy schedules to attend. Please do attend our follow-up webinars as well. We will send out emails to all MSART members, and it'll be all over our social media as well to let everybody know when we've got lots of interesting topics. This is our next webinar scheduled for the 13th of June, where Steve Levitt will be talking about optimization without compromise from OPU to embryo transfer. And I think we've got a promo for the one following that. Yep, this is on the 27th of June. Mr. Stephen Yap, who is a geneticist from Alpha IVF, will be talking about salvaging euploid blastocysts from abnormally fertilized zygotes. Quite an interesting topic in IVF through biparental testing and ploidy assessment. So what we try to do with most of our MSART webinars is to bring topics that are not only familiar, that not only are most of the people who are tuning in familiar with, but with something different and a new agenda. Also, I'd like to remind everyone again, for the second straight year, we will be having our physical MSART conference on October 5th and 6th in Kuala Lumpur. It's going to be held at the Sunway Convention Center. And our theme for this year is looking within to grow beyond. We've got an exciting lineup of speakers and all sorts of fantastic things for you to learn from. So for those people who haven't registered for the CME, please do so. We really look forward to seeing everyone there. Now, without any further ado, let's get to today's meeting. So first of all, let me go over the agenda. I will be introducing the speaker and of course his topic, and then he will go through his slides and speech. Subsequently, we will have about 15 to 20 minutes for a Q&A. So please submit your questions via the Q&A app on your Zoom itself. Submit the questions in the box and we will address them during the Q&A session of the end of the webinar before we close. Okay, so without any further ado, let me tell you about my dear friend, Dr. Senthi. Dr. Senthi is not just a friend, he's also a colleague. He obtained his undergraduate degree in Chennai, and he subsequently attained his membership in the Royal College of Obstetricians and Gynecologists in 2013. After that, he has had a storied career in government service, working in Ministry of Health hospitals such as MOA, KLGH, and Hospital Sultanah Aminah in Johor Bahru. He then went for further training in fertility and laparoscopic surgery under Dr. Selva at Makota Medical Center before completing his fertility training with Dr. T at Metro IVF. He is presently the resident fertility specialist at Metro IVF Johor Bahru. He is a really passionate doctor, really nice chap, who's very interested in helping people. You should hear some of the feedback from some of the couples who go to him. They're so happy with what he does for them. And I'm sure he'll be able to bring that amount of knowledge, compassion, and care to today's topic. So for today's topic, he'll be taking a look at HMG, human menopausal gonadotrophins versus recombinant LH and recombinant FSH preparations. It's something that's been there on and off for the last 10 to 15 years, but obviously there's always new data and we're always interested to learn. I think all IVF doctors, all of you tuning in, some of you are IVF physicians, some are embryologists, some are nurses, all of you know your own doctors have got their own thing, what they like and how they like to prepare it. So let's listen to Dr. Senthi and see if he can give us some valuable insights into that. Dr. Senthi, you're up.
Thank you very much, Dr. Praveen, for the kind introduction, and very good evening to everyone who have tuned in. First of all, I would like to thank the MSART team for giving me this opportunity to be tonight's speaker. It's a privilege to be a speaker for MSART. So the topic of my presentation today is rather factual. So it's aimed to understand the differences in outcomes among recombinant luteinizing hormone, recombinant follicle stimulating hormone, and urinary derived follicle stimulating hormone, UFSH, in IVF stimulation. So first, part of the presentation is to compare the HMG versus recombinant FSH. And then the second part would be to examine the details of adding a recombinant LH in the stimulation protocol, which is has been there for some time, but I think still not widely practiced. So I will be talking about which type of group patients will benefit most from those with addition of recombinant LH. So let's start with a brief history of the hormone, the ovarian stimulating hormones. First, start with the human menopausal gonadotropin. So the HMG was extracted from the urine of postmenopausal women. It reflects the urine of the postmenopausal woman reflects a high level of hypergonadotropic state of hormones, which that is high levels of FSH and LH. So HMG contains a mixture of both FSH and LH. It may also contain small amounts of HCG. So HMG was initially successfully extracted from human menopausal urine since 1949 and is successfully introduced into clinical practice from 1961. Earlier preparations contained FSH and LH in equal proportions, but subsequently it was recognized that FSH is most critical for the follicle development. So therefore, newer purified preparation came into use with very low LH content. So the FSH by LH ratio was higher in subsequent preparations and up to the highly purified HMG. So the examples of HMG available now is HUMOC, is a highly purified FSH LH in 1:1 ratio, which is produced by Bharat Serums. Next is a Gynogen, highly purified. It also contains a highly purified urinary FSH and LH in 1:1 ratio. And Manopure, which comes in a vials of 75 IU of FSH and 75 IU of LH. And Pergonal, which is not so commonly available. It contains 75 IU of FSH and 75 IU of LH. Next, discovery of the recombinant FSH. FSH is a glycoprotein heterodimer consisting of two polypeptide units, namely alpha and beta. The alpha subunit is common to all the anterior pituitary hormones like FSH, LH, HCG, TSH, and so on. But the biological specificity is conferred by the beta subunit. The amino acid sequences of alpha and beta subunits were described in late 1970s. The gene for beta subunit was cloned in 1985. Why the need for the recombinant FSH initially? The demand for IVF was ever increasing over the time. HMG preparations require large volume of urine of postmenopausal urine. It's like needed millions of liters of urine needs to be collected to produce the HMG. The available urine from donor was not sufficient to meet the increasing demand. And we need FSH in industrial proportion. So until 1995, urine of postmenopausal woman was the only source of production of human-derived gonadotropin preparations. The world's first recombinant FSH preparation was Gonal-F, that is a polytrophin alpha, came into the clinical use in 1988. Subsequently, another recombinant FSH was introduced in 1995, that is Furagon, which is actually polytrophin beta. The most significant advantage of recombinant preparations over urinary preparations are that recombinant preparations permits FSH to be quantified reliably by protein content, that is mass in mg, rather than by biological activity, which is the case with the urinary derived FSH preparations. In 2007, a fixed combination of preparation, that is 2:1, that is recombinant human FSH in 150 unit and recombinant human LH in 150 units was registered. So the preparation is available is 2:1, means 75 in 150. So the total units will be 225. Of that 225, 150 will be recombinant FSH and 75 will be recombinant LH was registered in Europe. Initial use of this preparation was meant for women with severe intrinsic FSH and LH deficiency, hypogonadotropic hypogonadotropism, but subsequently the use of this preparation is extended for poor responders, women with low ovarian response, and women above 35 years of age. We will discuss in detail in the later part of this presentation. So today's discussion aims to present the available evidence comparing the outcome of control ovarian stimulation using HMG, recombinant FSH, and recombinant LH. We are trying to compare the outcomes using HMG, recombinant FSH, and recombinant LH. Hope I'm not confusing. Okay, so we want to go by evidence-based medicine. There are lots and lots of studies available. There are so many, too many to number, but I chose three large studies comparing the HMG and recombinant FSH. I have listed out some commonly available studies. One is the Pasho, Roti, Requena, Terranija, and there are four more: Buller, Fabregas, and Dahan and Rivelli. I chose the first three because these are the multi-center RCT studies. The last three are retrospective and one was matched case control. So I choose the first three to examine what does these studies actually say about. Okay, first is the findings of the study in summary says that the significant increase in live birth rate with HMG compared to recombinant FSH. I repeat, the studies show there is a significant increase in live birth rate with HMG compared with recombinant FSH. The superiority of HMG was attributed to the LH activity of HMG preparations. LH activity said to modulate follicular genesis, improve embryo quality, and endometrial receptivity. Now, let's look at the studies in detail. First is this Pasho-Reti. Pasho-Reti, the intervention is a multi-center prospective randomized control trial. The gonadotropin preparations used were HMG 225 IU versus Pergoveris. That is the fixed combination of 2:1 human recombinant FSH 225 and human recombinant LH 112 from day one of stimulation. This is a bit again different because most of us tend to add the LH component from day 6 onwards because that is what we think that the LH receptors are available for stimulation. But here is a bit different. The LH was started from day 1 of the stimulation and the preparation is 2:1. Recombinant FSH to recombinant LH is 2:1. So what is the outcome of this study? This study was conducted in Italy. It involved 122 cases. Before starting of the trial, the women were down-regulated, pituitary down-regulation done by triptorelin, decapeptyl 0.1 mg daily. The study groups were divided into two groups. The starting dose was 225 HMG or 225 units of Pergoveris, just 2:1. HCG 10,000 IU was given when 50% of the follicles reached 18 millimeter and E2 level of 2540 picogram was attained. Oocyte retrieval was done 36 hours after the HCG administration. Of note, in Italy, only 3 oocytes are permitted to be inseminated. So good quality oocytes were chosen for insemination, not all oocytes. The outcome is that group A is HMG, group B is Pergoveris. We can see from the slide, Pergoveris allowed higher number of oocytes to be retrieved, average 7.8. But of note is HMG gives more mature oocyte compared to group Pergoveris. So Pergoveris gives higher number of oocytes, but HMG gives higher mature oocyte. Okay. The days of stimulation was shorter with Pergoveris, bit long with HMG. However, the total dose of Pergoveris used was 4,800 units on average, a bit lower for HMG. And risk of OHHS was high for Pergoveris. So the most important here is that Pergoveris allows higher number of oocytes to be retrieved, but HMG gives more mature oocytes. So this study showed that treatment with HMG or recombinant FSH and LH could achieve same pregnancy rate, same implantation rate, and embryo quality despite the differences. But HMG gives better quality oocyte compared to Pagovaris. So in terms of pregnancy rate, implantation rate, and embryo quality, there's no difference between the two. So that is one. The next study I examined was Requena. It is an observational study of 50 oocyte donors received either combination of recombinant gonadotropins, RFSH plus RLH, or mixture of urinary gonadotropins, HMG plus purified urinary FSH. Results: more oocytes obtained with RFSH than UFSH, but better quality oocyte with UFSH. As before, as the previous study, the similar picture. But however, the ongoing pregnancy rates were similar in both groups. The next is the study conducted in Iranian hospital. This study involved 140 cases each, divided into 70, is aimed to compare the use of recombinant FSH plus recombinant LH versus HMG plus recombinant FSH. Okay. Group A, RFSH from day 2 and HMG added from day 6, which most of us do. And group B, RFSH from day 2 and RLH added from day 6. So the measures, the outcome measures were biochemical pregnancy rate, clinical pregnancy rate, live birth rate, and miscarriage rate. The results: no significant difference in total number of follicles and total number of M2 oocytes between the groups. However, the clinical pregnancy rates and live birth rates were significantly higher in RFSH and HMG group compared to RFSH and RLH groups. So this study showed the higher pregnancy rate with RFSH plus HMG when the HMG was added from day 6. Now, the most important is the Cochrane review. It's a systematic review of 36 RCTs by Monique et al. Comparing the use of recombinant LH plus recombinant FSH versus recombinant FSH alone. So to check whether the addition of recombinant LH is brings any benefits or not. So it's a Cochrane database review. At the outset in the review, it says that major limitation in this review was the reporting bias, poor reporting of methods, how the studies were actually conducted, and the quality of studies were reported as very low to moderate. So the Cochrane review says that when it comes to the live birth rate, when we compare RLH plus RFSH versus RFSH alone, when we compare the live birth rate, Cochrane database says that there's insufficient evidence to determine whether there is a difference between RLH plus RFSH and RFSH alone in terms of live births. So the evidence is insufficient. The ovarian hyperstimulation rates, there's no difference between the preparations. And ongoing pregnancy rates, the use of RLH combined with FSH probably improves the ongoing pregnancy rates compared to RFSH alone. This is the Cochrane review. And the miscarriage rates, the use of RLH combined with RFSH probably makes little or no difference no difference in miscarriage rates compared to RFSH alone. And the cycle cancellation rate, there may be little or no difference between recombinant LH combined with recombinant FSH versus recombinant FSH. Overall conclusion, according to Cochrane database, there's insufficient evidence to encourage or discourage stimulation regimes that include RLH combined with RFSH in IVS-IFSI cycles due to poor quality studies. So from these studies, what is apparent? What is apparent is there's no firm conclusion can be drawn in favor of a particular source of preparation containing LH activity. When RLH is compared with HMG, it was found that RLH yields higher number of oocytes, lower percentage of matured oocytes, lower ongoing pregnancy and live birth rates, and it carries higher risk of ovarian hyperstimulation syndrome. Then why we need to use recombinant LH then? So now we look at the groups. Which particular group of cases may benefit from recombinant LH addition from the beginning of the stimulation? So we all are quite familiar with this Poseidon criteria. There are 4 groups: Group 1, Group 2, Group 3, and Group 4. Group 1 is a very good profile, less than 35 years, AMH more than 1.2, and AFC more than 5. Okay. Group 2 is the older age group woman. Group 3, the AMH is very low. It's a low ovarian response, but young woman. Low ovarian reserve with young woman. Group 4, woman of higher age group, and low ovarian reserve. Group 1, Group 2, Group 3, Group 4. Okay. Now, who will benefit most from recombinant LH? Patients with sufficient pre-stimulation ovarian reserve parameters that have unexpected hyporesponse to monotherapy. This mostly falls under Group 1 patients. They have unexpected hyporesponse to FSH monotherapy. For this group of patients, RLH can be started either during mid-follicular phase or on the to rescue of the ongoing pregnancies, ongoing stimulation cycle, or stimulation day 1 is recommended or can be considered in subsequent cycle. So patients with sufficient pre-stimulation ovarian reserve parameters that have unexpected hyporesponse to FSH monotherapy. This means this comes under Poseidon group 1. Okay. Woman of 36 to 39 years, RLH, if is to be started, should be started on stimulation day 1. This actually goes to group 2 Poseidon criteria. Okay. Systematic review done by Carlo, and they have investigated 6 populations. Women with hyporesponse to recombinant FSH monotherapy, women at advanced reproductive age, women co-treated with GnRH antagonists, women profoundly suppressed LH levels after administration of GnRH, normoresponder to prevent ovarian hyperstimulation, women with poor response to ovarian stimulation. Okay. Recombinant LH is found to be beneficial in women with adequate pre-stimulation ovarian reserve parameters and unexpected hyporesponse to recombinant FSH monotherapy. This is the Poseidon group 1. Women of 36 to 39 years of age. This is Poseidon group 2. There is no evidence that, this is most important, there's no evidence that recombinant LH is beneficial in young normoresponders co-treated with use of GnRH antagonists. So we cannot add RLH to improve the number of oocytes or quality of the oocytes or the quality of the embryo, or to improve the implantation or the ongoing pregnancy rate in normoresponders. There's no evidence to support that practice. Number 4, the use of recombinant LH supplementation in women with suppressed endogenous LH levels due to GnRH analogs and in poor responders remain controversial. According to this review, the use of recombinant LH just to prevent ovarian hyperstimulation syndrome warrants further trials. So, in conclusion, human recombinant LH yields higher number of oocytes per cycle compared to HMG at similar cost. Human recombinant LH yields lower percentage of mature oocytes. Human recombinant LH gives no additional benefits. Women less than 35 years of age and normoresponders. Human recombinant LH can be used in women with low ovarian reserve or poor responders in previous control stimulation cycles. This comes under group 3 and group 4. That is, women with low ovarian reserve or poor responders in previous control ovarian stimulation cycles. So if this is the case, then there is a role for human recombinant LH. And this is the situation that most of us would encounter, whereby we know that they are very low AMH, higher age group, more than 35 or more than 35, low AMH, and low AF central follicle counts. So these are the women who are low ovarian reserve. This group of women will benefit from human recombinant LH preparation started from day 1 of the stimulation. In terms of conclusion for HMG and urinary FSH versus recombinant FSH, no difference in live birth rate. Urinary FSH versus recombinant FSH. Lower live birth rate when recombinant FSH compared with highly purified HMG. And so the overall conclusion is all these gonadotropins are equally safe and effective. So there is insufficient evidence to encourage the practice of using one gonadotropin compared to another when it comes to HMG, highly purified HMG, or recombinant FSH. So I hope I've covered most part for the human recombinant LH use in IVF stimulation protocol.